Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hello, welcome to this Medscape educational program entitled Narcolepsy and Idiopathic Hypersomnia as 24-Hour Conditions, Prioritizing Sleep Quality. I'm Dr. Michael Thorpe, Professor of Neurology at Albert Einstein College of Medicine and Director of the Sleep-Wake Disorder Center at Montefiore Medical Center in the Bronx, New York. We tend to think about narcolepsy and idiopathic hypersomnia as being daytime conditions, but what I'm going to present to you is information that shows that these are also very significantly nighttime conditions as well. They're really 24-hour-a-day disturbances. This activity will include discussion of therapeutic options, and there will be off-label mention of medications, and I will present those and discuss those at the time. Okay, so what are the central disorders of hypersomnolence? This is the latest diagnostic classification criteria from 2023, and we can see that narcolepsy type 1 is associated with loss of the orexin from the hypothalamus, and it's probably an autoimmune reaction that causes a destruction of orexin, and it causes the symptoms of narcolepsy, which include chronic excessive daytime sleepiness. If you were to measure orexin, or also known as hypocretin, if you measured it in the spinal fluid, you would find that it's low or absent. And typically these patients have cataplexy. And for sleep studies, we tend to do the overnight polysomnogram. If this shows as REM sleep onset within 15 minutes, it helps confirm the diagnosis. And we would do a daytime multiple sleep latency test, which if it shows a mean sleep latency of 8 minutes or less with 2 or more sleep onset REM periods, then that's diagnostic for the type 1 narcolepsy. Type 2 narcolepsy, we don't know the pathology. It may be related to some subtle loss of orexin. We just don't know. Again, they have daytime sleepiness, and if you were to measure that hypocretin level in the CSF, it would be normal. They don't have cataplexy, but they would have the same sleep study findings. The sleep onset REM period on the nighttime sleep study or on the multiple sleep latency test, the mean sleep latency of less than 8 minutes and 2 or more sleep onset REM periods. Now, idiopathic hypersomnia, the pathology is unclear. Again, these patients complain about excessive daytime sleepiness. They don't have cataplexy or other features consistent with the diagnosis of narcolepsy. And if you were to do an MSLT, they would either show a mean sleep latency of less than 8 minutes with less than 2 sleep onset REM periods, or you can measure sleep over the 24-hour period, and if they have more than 11 hours of sleep in 24 hours by polysomnography or actigraphy, then that's consistent with the diagnosis of idiopathic hypersomnia. Okay, so here you can see the main characteristics of those 3 different disorders. As I mentioned, they all have sleepiness. NT1 is the only one that has cataplexy, the low CSF orexin, but both NT1 and NT2 have the sleep onset REM period. So the abnormal REM sleep is a characteristic of narcolepsy, not of idiopathic hypersomnia. Although abnormal REM sleep phenomena can occur in idiopathic hypersomnia, it's just that they're not frequent like they are in narcolepsy. And sleep inertia is another feature which is typically seen in idiopathic hypersomnia, as can be the long sleep time. Some of those patients have a long sleep time, greater than the 11 hours and 24 hours with a long nocturnal sleep duration. or some of them may not have that, but just have the sleepiness on the MSLT, as I mentioned. So this shows you the classic sort of pentad of symptoms for narcolepsy: the sleepiness, the cataplexy, the disrupted nighttime sleep, and also abnormal hallucinations that can occur at sleep onset or sleep offset, and same with sleep paralysis, a feeling of sleep paralysis when the patient's awakening or as they're falling asleep at night. In type 2, you have the same features, but you do not have the cataplexy, so they can still have hallucinations, the sleep paralysis, and the disturbed nocturnal sleep. In idiopathic hypersomnia, we have a sleepiness. We can have that long nocturnal sleep episode. And one of the symptoms that's very common in idiopathic hypersomnia, particularly those that sleep long at night, is sleep inertia, a feeling of being unable to awaken easily when you awaken in the morning. So the patient's drowsy and often confused. Again, these patients don't have features of narcolepsy, so the CSF orexin levels would be normal, and there's no cataplexy. Typically, the idiopathic hypersomnia occurs in late adolescence to early adulthood, but narcolepsy very often occurs before that. The median age of onset is around 16, so a little later onset for patients with idiopathic hypersomnia. Now, when you come to assess patients with excessive daytime sleepiness, you need to differentiate it from fatigue. And sleepiness is a tendency to fall asleep. So patients with sleepiness need to have episodes where they tend to fall asleep at inappropriate times. And in the population, sleepiness can occur in 3 to 23%. In narcolepsy, of course, and idiopathic hypersomnia, it's always present. And that's different from fatigue, which is a sensation of tiredness and exhaustion. And this typically is a very common symptom in primary care, affecting up to 45% of patients seen in primary care. But these patients don't fall asleep, and it's typically associated with medical or psychiatric disorders. There are a number of fatigue scales that can be used for measuring fatigue, but fatigue is not the same thing as sleepiness. Now, sleep inertia typically occurs. It can occur in both narcolepsy and idiopathic hypersomnia. It's sometimes known as sleep drunkenness, although we don't like that name so much as it has a slightly pejorative connotation with it. So sleep inertia is a better term. And it's this difficulty waking up in the morning. And very often these patients will hit the snooze button and go back to sleep again. They can have long naps, and when they awaken from them, they feel refreshed because they have a sleep inertia. And it's a resistance to being awoken. Typically, these patients find some irritability on awakening because they don't like to be awakened. And they may also suffer from various autonomic behaviors. So they may do things and not realize that they've done these things because they're in a half-wake, half-sleep state. Now, the burden of narcolepsy symptoms are functional, psychosocial, and they affect the quality of life. Of course, there's the daytime sleepiness, and the disturbed sleep. It can be a major factor for up to 50% of patients with narcolepsy. They may have these automatic behaviors where they're sleepy and they have microsleeps and they tend to do things and have no memory for doing it afterwards. And of course, cataplexy occurs in those with the type 1 narcolepsy, but there are these other REM sleep phenomena that can occur. Feeling of being unable to move when awakening or falling asleep at night. And that occurs in up to 40 to 80% of patients with narcolepsy. And then there are the hallucinations, sleep-related hallucinations that can occur at sleep onset or as they're awakening in the morning. And of particular note is that sometimes these can be auditory hallucinations. And again, this can occur in somewhere between 40 to 80% of narcolepsy patients, more commonly seen in the type 1 narcolepsy patient than the type 2. Now, there is a major burden to the symptoms of excessive daytime sleepiness. They interfere with patients' usual daily activities and affect concentration, memory, and attention. And of course, patients may suddenly fall into sleep episodes. They can have what we call sleep attacks, where it comes on and it's irresistible sleep that occurs. That may even occur while they're being pretty active. They get this overwhelming desire to fall asleep. And then they have these automatic behaviors that I mentioned, which are micro-sleep episodes that block out memory formation, so they do things and have no memory for doing it. And you can see on the right-hand side a bar graph which shows the prevalence of many of these symptoms. Now, cataplexy, of course, has a big burden associated with it as well. Sometimes it can be falling to the ground with the buckling of the knees, or it may be head dropping down, or slurring of speech. In fact, slurring of speech is one of the major concerns of patients with narcolepsy. They don't like the slurring of speech, and that can be very embarrassing to them. They may also tend to drop things if holding things. It may be a lack of coordination. Many of these patients regard themselves as being clumsy. And you can see that about 24% of patients will have complete cataplectic episodes where it affects the whole body and they fall to the ground or feel as if they're going to fall to the ground. But 48% have those episodes plus some minor episodes, so maybe just the head and neck or the arm or just one leg that seems a little bit weak. That occurs in about 46% of patients. Injuries are not that common. For most patients with narcolepsy, they're aware when they're going to have a cataplectic episode, so they tend to be able to get themselves to a chair if they feel weakness in the legs. But that doesn't always happen, and some patients do falls to the ground where they injure themselves. And you can see the numbers indicated in the slide on the right-hand side there. Now, as I mentioned, narcolepsy and idiopathic hypersomnia are not just disturbances during the daytime, but disturbances at night. And here we see effect of narcolepsy on sleep architecture. And these three studies, and you can see controls in the bar on the left in each of these studies, and narcolepsy on the left and the controls on the right-hand side. And you can see that there are differences in the number of sleep stages. There's more light sleep seen in narcolepsy. There is less stage 2 sleep. They tend to have less of a deeper sleep stages. And so overall, it results in poorer sleep quality. And this is pretty consistent across studies that patients with narcolepsy will have this disturbed sleep architecture on nighttime sleep. And here we can see some data with regards to idiopathic hypersomnia. It also affects nighttime sleep, but in a slightly different way. The sleep efficiency is a little higher than we see in controls. They may sleep longer at night, those with the long sleep time, and that may be problematic because they want to have a shorter sleep time and be able to get up in order to get to work. And total stage into sleep is increased, as is REM sleep. They may have more REM sleep. So there are differences in the sleep that we see in patients with idiopathic hypersomnia compared with those normal controls. So the clinical considerations in the treatment of idiopathic hypersomnia are that treatment should first address daytime sleepiness, the sleep inertia, and the long sleep time. And we need to take into consideration patient preferences in deciding on appropriate treatment. We need to consider the comorbidities that can occur with the disorders, particularly in idiopathic hypersomnia. We often see depression and other mood disorders that can occur. And when we come to evaluate treatment, again, we often need to involve the patient in this and focus on their particular symptoms. For the patients who have long nocturnal sleep, they may need different treatment from the patients who don't have the long nocturnal sleep and have daytime sleepiness. And then we need to evaluate the treatment response in patients. So monitor the patient's symptoms at each visit. You can use the typical validated scales, such as the Epworth Sleepiness Scale, or you could use the Idiopathic Hypersomnia Severity Scale, which has a number of measures related to nighttime sleep, daytime symptoms. That scale is not a diagnostic scale, but it is a very useful scale for assessing change in symptoms in a patient with idiopathic hypersomnia. So let's talk a little bit more about the treatment options in idiopathic hypersomnia. First of all, there are behavioral, non-pharmacological treatments. Good sleep hygiene is absolutely essential for all patients. In fact, all patients with any type of sleep disorder needs good sleep hygiene. What that means is a regular time of awakening in the morning, because so much is tied to our time of awakening, our body temperature, cortisol, and so many other biochemical parameters that you measure, and also being in bed for an appropriate amount of time. So it's an appropriate amount of time is the amount of time the patient requires physiologically to get to their sleep, and they shouldn't have prolonged periods of being awake in bed at night. So a regular sleep-wake pattern, absolutely essential. Taking naps may be helpful for some patients, and again, they should be short, less than 15 or 20 minutes, not prolonged naps, so they take away from nighttime sleep. Now, for idiopathic hypersomnia, low sodium oxybate was approved in 2021. It's the only FDA-approved treatment for the treatment of idiopathic hypersomnia. But there are other medications that have been used but are used off-label. And these include a variety of things, including modafinil, which there's been some data to suggest that can be helpful treating daytime sleepiness in idiopathic hypersomnia. The antibiotic clarithromycin, surprisingly, can be very helpful in treating idiopathic hypersomnia, but there are concerns about long-term use of an antibiotic. Pitolisant, which has undergone studies but is not approved, but has shown some benefit. And then there are other forms of oxybate, such as sodium oxybate, and the once nightly oxybate is under investigation at the present time. So treating the sleepiness and cataplexy in narcolepsy, we would typically use oxybates and pitolisant. These are the medications that can address both sleepiness and cataplexy. They're the only two FDA-approved drugs that can help sleepiness and cataplexy. With the oxybates, there are several different forms. As mentioned, once nightly long-acting, and then there's twice nightly low-sodium formulations. Side effects tend to be around sedation and nausea. Gastrointestinal side effects are very common, but there can be a variety of side effects, including weight loss, and you have to be careful in the presence of sleep apnea because it may worsen that. And pitolisant, it's usually titrated up from a low dose to a maximum dose of 35.6 milligrams. Typically, patients taking 2 tablets of 17.8 milligrams to get to that dose. And headache, insomnia, and nausea are common side effects. Pitolisant is a different type of drug because it's an H3 inverse agonist, increases histamine. Now, when we address daytime sleepiness, we can use a variety of medications that are FDA approved for the treatment of sleepiness and narcolepsy. There are the modafinils, regular modafinil, and the longer acting form of armodafinil. We typically would use 1 or 2 tablets of modafinil. Sometimes we use a tablet in the morning and a tablet at midday for some patients. With the armodafinil, it's usually once a day. And the good thing about armodafinil is that the 250 milligram dose of armodafinil is equivalent to 400 milligram, the 2-tablet form of regular modafinil. It's pretty well tolerated, the modafinils. The headache, nausea, nervousness can occur. Stevens-Johnson has been reported very rarely in children, and so one needs to be somewhat cautious if you use modafinils in children. Not FDA approved for children. And then there's solriamfetol. This is a norepinephrine dopaminergic reuptake inhibitor. The modafinils tend to have most of their effect by affecting dopamine, but this one affects norepinephrine as well. Very effective agent for improving alertness. And it's taken from 75 to 150 milligrams once a day in the morning. Somewhat similar side effects are seen with modafinil, with headache, nausea, reduced appetite, insomnia, and anxiety. Now, there are other treatments that we can use, although some of these methylphenidate and dextroamphetamines formulations are FDA approved for narcolepsy. In general, we're using these less and less as we get more specific medications for the treatment of narcolepsy. These medications, often patients that have been on medications for many years are taking these medications, not started first line for many patients these days. We use the newer more effective agents. And in general, these are being somewhat phased out. And the reason being that they can cause a whole variety of symptoms. They stimulate most body systems, so they can cause central nervous system, mental disorders, hypertension, irritability, etc. And so in general, we try to avoid these medications as much as possible and use the newer, more specific medications. Now, there are also alternative treatments for the treatment of cataplexy and narcolepsy. None of these are FDA approved, but we've known for many years that these can be effective at suppressing cataplexy, and these are antidepressants, typically that have norepinephrine reuptake inhibition properties to them. Venlafaxine is probably the most effective and the most widely used one, but fluoxetine and clomipramine have been used as well. We use these again less often now that we have pitolisant and we have oxybates available, which are very effective at suppressing cataplexy. But in some cases where patients can't take those other medications, then using these antidepressants off-label is an option. Now, oxybates do tend to help the disturbed nighttime sleep, and they can help that disturbed sleep architecture. On the left-hand side, we can see a study from the once-nightly formulation of oxybate looking at sleep stage shifts and showing benefit of the once-nightly oxybate on improving sleep stage shifts, so it can help to consolidate nocturnal sleep. And on the right-hand side, we can see a DUET study, which is a phase 4 study with the medication, the low-sodium oxybate. And this also showing improvements in terms of reducing sleep stage shifts throughout the night in patients with narcolepsy. So the oxybates have the advantage of not only helping the daytime sleep and the symptoms, but also helping the nocturnal symptoms. Now, here's some information with regards to solriamfetol. Solriamfetol improves sleepiness in type 1 narcolepsy and type 2 narcolepsy, and you can see here very clear dose-related response on the maintenance of wakefulness tests. These are some of the best data we have for improving sleepiness in patients with narcolepsy. And although this shows 300 milligram dose in the light blue, that's not approved by the FDA. Only the 150 milligram dose was approved, but it greatly improves daytime sleepiness as shown by the MWT, and on the right-hand side, the Epworth Sleepiness Scale. This is the data with regards to pitolisant. They used an active comparator, modafinil, which you can see in red, and so the effect on daytime sleepiness was somewhat similar to the effect we see with modafinil, but it does have the added benefit of being able to improve cataplexy, whereas modafinil does not. So adjusting therapy to manage the complex symptoms of narcolepsy. So as I mentioned, there are a number of medications that affect excessive daytime sleepiness: oxybates, pitolisant, modafinil, armodafinil, and solriamfetol. For cataplexy, we only have the oxybates and the pitolisant. And for the disturbed nocturnal sleep, there's only one medication that can really help that, which are the oxybates. In conclusion, I would just like to sum up by saying that narcolepsy and idiopathic hypersomnia are 24-hour-a-day sleep-wake disorders, not only affecting daytime sleepiness, but affecting nocturnal sleep. So you need to think of both of these disorders as 24-hour-a-day disorders and not just daytime disorders. So they impair cognition, both of them. They can affect safety of the patient and certainly affect quality of life. And there can be a variety of disturbances in nocturnal sleep. In narcolepsy, of course, we have the abnormal REM sleep phenomena that includes hallucinations, sleep paralysis, and vivid and frightening dreams very often, as well as the daytime REM phenomena of cataplexy. And in the idiopathic hypersomnia, of course, we have that prolonged nocturnal sleep with sleep inertia upon awakening in the morning that's very disturbing to patients. So sleep architecture is altered in both disorders, narcolepsy tending to show lighter fragmented sleep, and idiopathic hypersomnia showing long sleep time and altered REM sleep, non-REM sleep balance with more REM sleep occurring in the whole night. So the treatment goals include reducing the daytime sleepiness. In narcolepsy patients, we want to control the abnormal REM phenomena such as cataplexy, and improve the quality of their nighttime sleep and consequently improve daytime alertness. In idiopathic hypersomnia, we want to try to reduce that duration of nocturnal sleep and allow patients to awaken feeling more rested. So the options include those oxybates, awake-promoting agents, stimulants, and antidepressants, as I've discussed. So you need to consider therapies based on the symptom profile, the side effects, comorbidities, drug interactions, and of course regulatory considerations, as some drugs are approved and others not approved. And combined therapy is often typically required. So we may use combinations of the medications that I have discussed, and very often adding a medication like oxybate to help the nighttime symptoms, in addition to, say, for example, having a wake-promoting agent helping daytime alertness during the daytime. So I think we've come to the end of our time, and I thank you very much. I hope you've found this a useful discussion of narcolepsy and idiopathic hypersomnia, and thank you for participating in this event.